أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل أعوذ برب الناس مالك الناس إله الناس من شر الوسواس الخناس الذي يوسوس في صدور الناس من الجنة والناس صدق الله العظيم.
Bismillahirrahmanirrahim. Assalamu alaikum. Today we will discuss the basic features of benign and malignant lesions of the liver on CT scan. I am Dr. Bini Zadi, working as consultant radiologist in Faisalabad Teaching Hospital, Faisalabad. First of all, we will enlist the benign hepatic lesions. These are hemangioma, focal nodular hyperplasia, liver abscess, echinococcus cyst or also known as hydrated cyst, mesenchymal hematoma, hepatic adenoma. The list of common malignant hepatic lesions is hepatocellular carcinoma, hepatoblastoma, fibrolamellar carcinoma, cholangiocarcinoma, and hepatic metastasis. This is an image of benign lesion of the liver on triphasic CT scan. Among radiology residents, any guesses? Yes, this is a hepatic hemangioma. This is the most common benign liver tumor. Its size varies from few millimeters to more than 10 centimeters, called giant hemangiomas. On CT scan, the hemangiomas are sharply defined masses with the same density as the vessels on non-enhanced contrast CT and contrast enhanced CT. As we can see that this lesion is same as, this density of this lesion is same as the aorta's lesion density, and the density on the arterial phase, the peripheral nodular enhancement is same as, the density is same as the aorta. Hemangiomas gives peripheral nodular enhancement with progressive centripetal fill-in. Small hemangiomas may show fast homogeneous enhancement, flash filling, and they are also called flash hemangiomas. However, the small HCC and hypervascular metastases may mimic small hemangiomas because they all show homogeneous enhancement in the arterial phase. By looking at the other phases, we can see that the enhancement pattern of the small HCC and hypervascular metastasis shows washout. However, the enhancement of the hemangioma is same as the blood pool at that time of the scan. Large hemangiomas can have an atypical appearance. They show, because of the central fibrous scarring, they show peripheral enhancement and gradual centripetal filling. Again, looking at the blood pool will help you. As we can see that the enhancement of hemangioma on arterial phase is same as the aorta at that time. And on portal venous phase, the peripheral filling of the hemangioma is same as the aorta at that time of the scan. This is another benign lesion of liver on triphasic CT. Any guesses? This is a focal nodular hyperplasia. It is the second most common benign tumor of the liver. It is a congenital vascular malformation that will be hyperdense in the arterial phase except for the central scar. The arterial homogeneous hyperenhancing lesion with central scar which enhances on the equilibrium phases. The typical focal nodular hyperplasia shows central scar that is hypodense in the portal venous phase and hyperdense in the equilibrium phase. We can see this is a central scar which is hypodense on the portal venous phase and shows enhancement on the equilibrium phase. The central scar may be found in some patients with fibrolamellar carcinomas, hepatocellular carcinomas, hepatic adenomas, or intrahepatic cholangiocarcinomas. The key to the diagnosis is the lesion stays isoattenuating to the normal liver in the portal venous phase and stays that way without a washout on the delayed phases. However, the hepatocellular carcinomas or fibrolamellar hepatocellular carcinomas shows washout on portal venous phase. This is another benign liver lesion. It is an hepatic abscess. Hepatic abscesses are variable in their appearance. They are peripherally enhancing, centrally low density lesions. It is very important to make the diagnosis of liver abscess because it is a benign disease that kills, and the radiologist may be the first to raise the suspicion. The hepatic abscess shows double target sign. It is a characteristic imaging feature of the hepatic abscess, which demonstrates on the contrast enhanced CT scan. As we can see, this is a peripheral hypodense rim of the liver parenchyma and inner hyperdense rim of the abscess wall. This is again a presentation of hepatic abscess with outer hypodense rim of the hepatic parenchyma and inner hyperdense rim of the abscess wall. Any guesses? Hydrated cyst. It is a fluid density cyst with frequent peripheral focal areas of calcification. These give some typical signs, which are water lily signs, which indicates a cyst with a floating or undulating membrane caused by a detached endocyst. As we can see in this image, that it is a water lily sign, detached wall of the cyst, and it also gives hyperdense internal septa within a cyst, showing a spoke wheel pattern. As we can see there is cyst within multiple cyst within a cyst, which is a multiple septa between daughter cyst inside mother cyst. It is also called honeycomb sign. This is now we will discuss the malignant hepatic lesions. This is a triphasic CT showing a arterialized lesion which shows washout on portal venous phase and delayed phase. This is a typical picture of hepatocellular carcinomas. Hepatocellular carcinoma is the most common primary malignancy of the liver. Male to female ratio is 4:1. This is rising in incidence attributed to a rise in hepatitis B and C. The risk factors for hepatocellular carcinomas are hepatitis B infection, hepatitis C infections, alcoholism, biliary cirrhosis, food toxins like aflatoxins, congenital biliary atresia, inborn errors of metabolism. On triphasic CT scan, the pictures of the typical imaging of the hepatocellular carcinoma is seen on triphasic CT scans, which shows 7.5% of cases may show focal calcification. However, the majority of the lesions shows arterial enhancement and portal venous washout. Some of the lesions shows late capsular enhancement. However, heterogeneous enhancement is also noted with central necrosis in large lesions. The typical feature of hepatocellular carcinoma is also tumor thrombosis, which shows dilatation of the portal vein, which shows the enhancement pattern same as the hepatocellular carcinoma, which enhances on the arterial phase and shows washout on the portal venous phase. And this tumor thrombus may show communication with the primary tumor. This is another malignant lesion of the liver, which shows central scarring. Yes, this is fibrolamellar carcinoma. These usually present as a single large, well-demarcated but non-encapsulated tumors with a central fibrous scar and fibrous band. The typical risk factor for HCC, like cirrhosis and raised alpha-fetoprotein levels, is absent in fibrolamellar carcinoma. This means that they present in non-cirrhotic livers. This is most commonly seen in young populations and adolescents, and they are not associated with raised serum alpha-fetoprotein levels, which is seen in HCC. The enhancement is usually arterial. The central scars typically shows persistent enhancement on delayed images. On arterial phase, the central scars shows no enhancement, but on delayed images, it shows permanent, persistent enhancement. The hepatoblastoma is a malignant lesion of pediatric patients. It is seen during first 18 months of the life. Again, male predilection is seen in hepatoblastoma with 3:2 ratio. And serum alpha protein levels are also frequently elevated in hepatoblastomas. Hepatoblastoma is usually seen as a well-defined heterogeneous mass, which is usually hypoattenuating compared to the surrounding liver, and frequently they shows areas of necrosis and hemorrhages. We can see a well-defined heterogeneous lesion, which shows internal areas of hemorrhages and heterogeneous enhancement. Another malignant lesion of liver which arise from the bile duct. It is the commonest type of bile duct cancer, is cholangiocarcinomas. The cholangiocarcinomas are the third most common hepatobiliary malignancy after HCC and gallbladder cancers. They have poor prognosis and high morbidity. They usually presents in the elderly, and again male predilection is seen. The increased incidence of cholangiocarcinoma is seen in patients with Caroli's disease, sclerosing cholangitis, intrahepatic calculi, or inflammatory bowel disease. The presentation of cholangiocarcinoma is seen as mass-forming lesion. They are typically homogeneous, low enhancement in attenuation on non-contrast scans, and they shows heterogeneous minor peripheral enhancement with gradual centripetal enhancement. The typical picture of cholangiocarcinoma shows capsular retraction and biliary dilatation adjacent to the lesion is suggestive of cholangiocarcinoma. As we can see on arterial phase, it is this is capsular retraction done by the liver, and peripheral biliary duct dilatation adjacent to the lesion. They are typical features of cholangiocarcinoma. As we can see, it shows minimal enhancement or arterial phase with gradual central fill-in on delayed portal venous phases and delayed phases. Any guesses? Metastasis. The liver is the most common site of metastasis. The most common organs of origin are colon, stomach, pancreas, breast, and lung. There are multiple types of metastasis. Some are hypovascular, some are hypervascular, some are calcified lesions, some are cystic lesions. The hypovascular metastases are the most common and occur in GI tract, lung, breast, and head and neck tumors. They have enhancing rim that can be seen on arterial, and portal venous phases. These are also called target lesions. Hypervascular metastases are less common and are seen in renal cell carcinomas, insulinomas, carcinoids, sarcomas, melanoma, and breast cancer. Best seen in the late arterial phase at 35 seconds after contrast injection. As I have already described that some of the metastasis shows calcifications, and the calcification is seen in metastasis of colon, stomach, breast, endocrine pancreatic carcinomas, leiomyosarcoma, osteosarcoma, and melanoma. Cystic liver metastases are seen in mucinous ovarian carcinomas, colon cancers, sarcomas, melanoma, lung cancers, and carcinoid tumors. Thank you. उनका ये होता है कि जो FNH है उसका पहले मैंने डिस्क्राइब किया है कि उसका जो डिलेड फेज होगा वो आइसो एटेन्यूएटिंग टू द लीवर होगा. वो FNH जो है वो बेसिकली लीवर की ही वेस्कुलर मैलफॉर्मेशन है. उसके सारे कंपोनेंट्स लीवर के होते हैं, बस उनकी ऑर्गेनाइजेशन चेंज हो जाती है, तो वो FNH होता है. दिस इज बिनाइन. जो फोकल फाइब्रोलैमेलर कार्सिनोमा है वो एनहांसमेंट शो करेगा और वॉश आउट भी शो करेगा विद सेंट्रल स्कारिंग. This is the image. Cholangiocarcinoma shows capsular retraction, as we know, with the adjacent biliary duct dilatation. This is a strong indication of cholangiocarcinomas. Okay. Hepatic cysts do not show any enhancement, and it is non-enhancing lesion, benign lesion, and hepatic metastasis shows wall enhancement. Peripheral nodular enhancement. कैसे होगा ये?